Once having located a spine, between the two fingers, make a skin wheel. And I like to use the skin wheel needle to explore trajectories. And then once I've established the ideal trajectory, then I will simply replace that with my introducer, which I'm orienting with the bevel up. And this will begin the loss of resistance portion of the procedure. So I'm matching my vertical angle, just moving the device over to my wheel. Now just getting it established in ligament. And I can remove the stylet and attach my loss of resistance syringe. And you can use either air or fluid. I prefer to use air since it reduces the possibility of confusion later in the procedure, but certainly saline is a possibility if that's your preference. So we attach the loss of resistance syringe, test for resistance, and then start advancing. And we test for resistance as we go. And there's resistance. So now we remove the syringe and we remove the needle, leaving a peel away taking us to the epidural space. Now we can proceed with step 2, which is placement of the device itself, and we will take advantage of that channel. So we orient the triangle cephalad. So with two hands and the triangles oriented cephalad, and advance until we start to feel some resistance, and then piercing the dura typically occurs within just a few millimeters and is a distinct click-give sensation. When that occurs, one checks for fluid because we now believe that the device is subarachnoid. Now we can move to step 3, which is advancement of the cannula. The step is initiated by stabilizing the cannula hub and then grasping the clear needle hub and rotating 360, disengage the two hubs, advance the cannula. At this stage, we initiate stage 4, which is peel away. So we're just going to peel the device out right to the skin and then leave it there. And now we can stabilize the needle hub and advance the cannula right into the patient. And it should go easily and smoothly, and remove the rest of the peel away. The patient may have a transient paresthesia, but as long as the paresthesia does not intensify or become severe, it's reasonable to continue advancing, and almost always the paresthesia will be transient. Whether or not one sees CSF, we now will insert the wick wire and attach the extension tubing. If one does not see CSF coming briskly back through the cannula, there are essentially two possibilities. One is that the end orifice is against some tissue, preventing fluid passage, or the other is that the device tip has, or at some point the device has become kinked or crumpled. The wick wire will solve the kinking or crumpling issue immediately, and if it does not, then it's probably the end orifice against tissue, in which case merely pulling back the entire device and watching for fluid in the tubing will essentially always be rewarded with the appearance of CSF. Once CSF is seen in the tubing, I like to passively fill the tubing rather than aspirate, because aspiration could suck tissue or nerve roots into the end orifice of the cannula, thus occluding it. So passive flow is better, although it does take some time to wait for the flow to fully fill the tubing. Once that's occurred, you can just put the cap on nice and tight, and we move to securement phase. In securement phase, we have a specially designed dressing which is designed to cradle the device and prevent the patient from feeling the pee under the mattress syndrome. It's a device, it's a foam dressing with strategic cutaways and cavities and an adhesive backing. And we typically like to fold the catheter hub cephalad against the patient's back. So we remove the adhesive backing, and using the side slit, surround the device with the adhesive dressing. It's now sticking to the patient's back, and now we can simply lay the hub of the device into the cavity on the dressing and then cover this entire dressing with a standard adhesive Tegaderm style bandage. The tubing then is routed over the patient's shoulder and taped with conventional tape. You may now dose with medication and titrate your anesthetic or analgesic regimen as clinical needs dictate.